Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. I'm Zak Kaesberg, your tutor, coach, and guide along the path to passing the CDR exam. My biggest passion is to help RDs and RDs to be just like you, to know how to effectively pass the CDR exam, and if that sounds like you, you're in the right place. If you're listening to the podcast in the current moment, I wanted to let you know that we're having a new RD Exam Ready Live hosted on YouTube this Wednesday, July 29th, 2026, 7 o'clock p.m. Central Time. That's going to be 8 o'clock Eastern Time, 6 o'clock Mountain Time, 5 o'clock Pacific Time. And if you get a chance to join us during this session, we're going to be reviewing a few MNT medical nutrition therapy topics together. So I'm going to pick a few disease topics for us to go through. We're going to do some clinical scenarios and practice questions associated with it. So I think it'll be just a great session for people who just need a little bit more clinical work, maybe some work on labs, medications, and just complex clinical scenarios in general. So please come join us on YouTube. Make sure you're subscribed, go to that live section, and make sure you get notified for when we're going to start that session on Wednesday. Despite what looks-maxing trends are going on or what we're all trying to do to avoid it, aging is something that is quite natural, and it's going to happen to all of us, I believe. As we age, we know that there's a physical, a psychological, a kind of psychosocial development that we all can go through during the aging process. We know that as someone ages, it's very dependent on what their lifestyle was like when they were a child, an adolescent, and an adult and beyond that is really starting to catch up with them at this age or not. And although not all older adults end up with having disease states, strokes, cardiovascular disease, it is this time that those risks can start to creep up, become more prominent, or actually start affecting our lives. Specifically, the normal physiological process throughout the body can affect our nutrition status, and nutrition becomes more essential in older adults. Today, I'd like to outline nutrition in older adults and help give you the pertinent information that you're going to need for exam day itself. I want to set the stage first on nutrition later in life. For most older adults, the need for nutrition depends on their disease, their lifestyle, and it could require them to have increased or decreased needs because of it. As we age, the different organ systems of our body are also changing as well. For instance, in our cardiovascular system, our arteries, they start to become rigid and stiff. That can increase your blood pressure as you age. Additionally, the quality of the heart starts to decrease just a bit. You get less elasticity in your blood vessels. Your blood volume and your stroke volume also decreases and takes a dip. Your hormones in your endocrine system are certainly affected. We see reduced levels of estrogen in postmenopausal women. We also see reduced levels of testosterone for men, so men are also going to get it as well here. We see reduced amounts of growth hormone being produced by the thyroid gland. We even see reduced ability to convert provitamin D to previtamin D in the skin. To stick with this endocrine system, we also see that as people age, they tend to develop prediabetes and even diabetes, and it isn't really a change in their diet. A lot of the time, it's because they have reduced levels of glucose tolerance in the body that occurs as we age. Those cells become less receptive to insulin and to glucose as we go through the aging process. The gastrointestinal system starts to see reduced secretions of things like saliva, mucus, reduced secretions in the stomach, as well as pancreatic enzymes. With that reduced level of hydrochloric acid in the stomach, we also end up with decreased ability to have intrinsic factor in the stomach, as well as be able to free B12 from its protein-bound molecules. We're also going to have decreased ability to digest and break down certain vitamins and minerals, like iron and its love for acidic environments. The next piece is about musculoskeletal system, and it speaks a lot towards body composition as well as macronutrient and kilocalorie needs. If you had to guess, would you say that older adults will gain muscle mass as they age or lose muscle mass as they age? Well, you'd be correct in thinking that they're going to lose muscle mass as they age. As you kind of think about that, you also are going to gain fat mass as you age. So simultaneously, we're gaining more fat, losing more muscle. We also have a decreased basal metabolic rate as we age. All those pieces add up together to say that normally older adults should be sure to meet their normal protein needs to help maintain their muscle mass, but also they're probably going to have reduced amounts of kilocalories in the diet because they have that reduced muscle mass and increase fat mass. So calories are going to come down a little bit once we get to that. In older adults, the nervous system also can be affected. Things like taste, appetite, thirst are all being decreased, as well as reduced use of the nervous system, sometimes making it difficult to walk, pick things up, eat, or basic daily functions. As we age, our kidneys also age a little bit. Oh no. Our kidneys will have reduced ability to filter out waste due to a lower number of nephrons and a slower GFR, or glomerular filtration rate. And even the respiratory system is affected by aging, decreasing our ability to breathe and have endurance as we get older. Now, those things are not there to worry you for the future. It's to help set you up a little bit about how nutrient needs change in an older adult. With older adults, make note, there's a few validated nutrition screening questionnaires that can be used to assess an older adult. Some specific ones are like the mini nutrition assessment, the malnutrition screening tool is effective, the short nutrition assessment questionnaire or the SNAC, and the subjective global assessment, the SGA, and lastly, the determine checklist, aka the nutrition screening initiative. Someday we're going to do our own thing just on those different screening questionnaires, but make note for yourself that those are the ones that are really specifically used for assessing older adults and nutrition status. Let's get into each of our nutrients now. Calorie needs in older adults. The primary goal is to maintain a healthy weight and body composition. The easiest way to determine an older adult's calorie needs would be to determine their basal metabolic rate. The Mifflin-St. Jewer formula can closely predict the energy requirements for healthy adults in general, and there was some validation done for adults up to age 80 using this same tool. Now, you don't have to use that for the RD exam, but it is to say that this is an effective tool. Keeping in mind, older adults' nutrient needs would really be dependent on so many things. Their disease state would determine if they had an increase for calorie needs beyond the basic level. If they're a very active older adult, they would of course require more calories. If they have a wound, a vent, a chronic disease, those would all be factored in to may give them more accurate increased calorie needs. But if we're saying a normal, healthy older adult, we could use the Mifflin-St. Jewer equation, and their calorie needs in general would be lower compared to a middle-aged adult, for instance. Carbohydrates in older adults is going to be sticking to the AMDR, or the acceptable macronutrient distribution ranges, for other adults. So it's still 45 to 65% of daily calories should come from carbohydrates. Keeping in mind, you're eating less calories in general as you're older. So that being said, if you're eating less calories and the carbs make up 45 to 65% of those calories, by reducing your calories, you're reducing your carbs. So this is kind of what we can think of here as we go through that. The big key is making sure older adults get enough carbohydrates, and especially getting high quality carbohydrates, specifically plenty of fiber. They should be selecting whole grains, eating whole grain rich foods, because those whole grains are going to contain much of the nutrients that they need as they get older. Remember, refined grains aren't going to have as much nutrient density unless they're being enriched and fortified. But still, I'd rather them just get a whole grain and get much of those other nutrients, not just what we enrich with. Also, we think about how dietary fiber helps us out with our blood lipid levels. We know that as you get older, your risk for cardiovascular disease is higher. So by increasing your fiber content, you're going to bring your cholesterol down, bring your LDL levels down, and other bad lipid numbers. For protein, it can be a little bit difficult to pin down the correct amount of protein for an older adult. You have a few factors that go into this. One of them is being the decrease in muscle mass, okay? But that might tell you that actually they need an increased amount of protein so they don't lose their muscle mass, right? That would be correct to think. We don't want them to lose muscle mass, so they need adequate protein, certainly. Another piece of it, though, is the fact that as they get older, your kidney function is also going down. So you don't want to overdo the protein because it's just going to further break the kidneys down, and their kidneys may go even faster. As you can see, it's a double-edged sword. The RDA that is set for protein for older adults is the same as for healthy adults. It's 0.8 grams per kilogram is the current RDA. There may be some benefits, though, in research for an older adult, consuming 1 to up to 1.5 grams per kilogram of body weight per day to help prevent the loss of muscle mass. What we're trying to pick out here is maybe we can help us out with a clinical scenario. So let's take scenario one. We have an older woman who is admitted to the hospital from a nursing home with confusion. Picture her. She doesn't exercise, she doesn't have renal issues, nor hepatic issues, and she eats 3 meals a day. Well, for that woman, I'm probably going to estimate her protein needs using zero point 0.8 grams per kilogram. She's not very active. She doesn't have a disease state. She eats enough throughout the day, it seems. So I would put her needs at zero point 0.8 grams per kilogram. Now let's take another situation. Let's say we have an older woman who goes on walks each day. She does a daily Pilates class. She volunteers. She does weightlifting, and she's pretty active. Well, I'm going to put her probably closer to the 1.5 grams per kilogram per day because she's almost like an athlete, a little bit how much she's working out, she's staying active. So, just like I would for a normal healthy adult, I would increase their needs too if they were that active. Then we also think of things if maybe if someone had a healing wound or some cancer going on, right? That would indicate a higher amount of protein and we would certainly just adjust their needs accordingly depending on the chronic disease state. Now for fat, the total amount of fat is still staying within the AMDR, okay? 20 to 35% of total calories. Correct. As we kind of look at our older adults, though, we want them to, of course, avoid our bad fats coming from saturated fats and trans fats, because those would only increase their cardiovascular risks or having cardiovascular diseases later in life. There is no specific cholesterol recommendation for older adults, but if I was to kind of recommend, I would say that we would want older adults to monitor their dietary cholesterol, or if they are diagnosed with high cholesterol, then we would be giving them recommendations on limiting cholesterol in the diet, in the types of foods. For fluid, I want you to think about fluids this way. As adults are getting older, they have a decrease in the muscle mass and an increase in fat mass. They're having a decrease in their total blood volume and decreased elasticity in their skin. This all points to the fact that most adults, as they get older, their needs for fluid is going to decrease. So your fluid needs generally decrease as you get older. When you don't have as much muscle, you don't have as much water to store that water into the muscle. When your kidneys are getting poorer as you age, I don't want to overwork them by giving them too much fluid, you see. A good recommendation we could use, though, is to say 1 milliliter of fluid for every kcal, because if they're reducing their kcals, then they will justly reduce their amount of fluid that they get in that same manner, which fits really well to me. Now let's get into specific nutrients. This is what I'm really interested in. Starting with vitamin A here, folks, fat-soluble vitamin A, odd one of how it acts on the body. Couple reminders. Vitamin A is fat-soluble, okay? So it's quite easy to overdose or overdo vitamin A because it binds and it sticks to fat in the body. Thus, if I have more body fat, I probably am going to retain more vitamin A. That's what we're seeing in older adults because as they're aging, their amount of body fat is going up. Also, another piece is that their liver stores more vitamin A as they get older, and they may even have increased absorption of vitamin A or decreased ability to metabolize and clear it from the blood. Especially with retinol binding protein, extra of that can just get filtered out by the kidneys. But if my kidneys aren't doing so well, then I'm going to have plenty of that protein to bind to vitamin A. You can see how all these things are kind of adding up to a high amount of toxicity when it comes to vitamin A. Even though we're seeing this increased likelihood of an overdose of vitamin A, we do not see an increase on the RDA for older adults. So despite that higher likelihood, the RDA for vitamin A is going to be 900 micrograms per day for men, 700 micrograms per day for women, which is the same as that of someone in their 30s, 50s, 60s, etc. Okay, so 700 women, 900 men. Big bad boy here is big vitamin D. And we know that bones and could be affected during aging. The RDA for vitamin D increases with aging. up from 600 IUs per day from someone in their 50s or middle aged, and jumps up to 800 IUs per day for someone that's in their 70s. In general, older adults do not consume enough vitamin D, and they do not get enough vitamin D from sun. Many of them are inside a lot of the day, and so they don't really get much of that sunlight that they would need for vitamin D as well. Why do they have such a high need for vitamin D? Well, it comes back to a little bit about bone mineral density, right? We know that as we age, our bone minerals are breaking down faster and further. And this influences why we need to get adequate amounts of vitamin D to help maintain that bone mineral density, avoid fractures, and keep ourselves nice and strong there. So that's just a good thing to remember a little bit when it comes to vitamin D and just putting together these pieces to what happens when we age. Vitamin E, as in Edward. This is our favorite little antioxidant, and it's going to help older adults with immune system function and cognitive status. The RDA for vitamin E is the same for older adults as it is for middle aged adults. The big benefit for vitamin E to older adults, though, is its ability to maintain their immune cell function and also maintain their cell membranes. Keep in mind, cell membranes are there to let things in that they want to, but also to keep things out. So, by having strong cell membranes with vitamin E, we can go ahead and prevent any pathogens, infections, things from moving its way into my body, my cell membranes, and we can help keep that barrier a little stronger there. Now, vitamin K, big vitamin K, one of our favorites because of its level in K, coagulation, right? Older adults don't eat enough vitamin K generally unless they are ones who consume plenty of produce and leafy greens. The RDA for vitamin K, or excuse me, the adequate intake that is set for vitamin K, is the same for middle aged adults as it is for older adults, that AI being 90 micrograms per day for women, 120 micrograms per day for men. We want them to maintain consistent vitamin K intake during this aging phase if they are healthy. If they are under the direction or use of warfarin or Coumadin, a blood coagulation medication, then we really want to make sure that they're maintaining normal amounts of vitamin K intake, the same intakes throughout the week, not varying that very much. We want them to just stay consistent because we know that that drug has an effect on coagulation and vitamin K has an antagonistic effect. Vitamin B12, if you had to guess, would you say it decreases as you get older or increases as you get older? Well, you'd be right in thinking once again, it's going to decrease as you get older. So the needs for vitamin B12 are greater as you age. You need more vitamin B12 in the diet. Many older adults don't adequately absorb vitamin B12 too. A big factor that I hinted towards in the beginning that as we age, we get decreased amount of gastric secretions in our stomach, and our stomach tends to atrophy and break down a little bit. It's because of this that you may see a decreased ability to split B12 from its protein carriers, as well as there being decreased intrinsic factor being released in the stomach in some older adults. Older adults have the same RDA for B12 as middle-aged adults. 2.4 micrograms per day is what's recommended, but older adults may benefit a little bit better from getting B12 from other sources. While we want them to be doing a food-first mentality, we can provide vitamin B12 injections or supplementation to them to ensure that maybe they're going to be retaining a little bit more B12 compared to someone with a normal healthy GI tract who's a bit younger. Folate or folic acid is going to be impaired throughout the same mechanism as B12. The full status can be affected by things like drugs, like antacids, diuretics, anti-inflammatory drugs can affect folate status as well. But that being said, the RDA for folate is the same for middle adults as it is for older adults, so I don't think it's too much to write home about. Iron. Iron for RDA, the RDA for iron is the same for middle-aged adults as it is for older adults. 8 milligrams per day is recommended, whether you're male or female. Older adults also have that risk of having more bleeding, blood loss, maybe not consuming enough iron, leading to microcytic anemia. So it'd probably be great if an older adult is getting adequate amounts of iron to help prevent any of that microcytic anemia occurring or a loss of hemoglobin due to excessive bleeding in their advanced age. A few more to go through, but still very important. Calcium's our next one. Now, we talked about vitamin D. We talked about how bone mineral density is being affected in older adults. We said we needed increased amounts of vitamin D due to this reason, but what do you think would happen with calcium? The exact same thing. Once again, you're correct in thinking the body is going to have increased needs for calcium for older adults. The RDA for middle aged people is 1,000 milligrams per day for men, 1,200 per day for women. For older adults, it's going to just stick to that 1,200 per day for men and women. Okay. So that's what we're going to see there. It's just 1,200 that goes across the board in that case there. So everyone's getting that highest level of vitamin or of calcium in that example. A disease state that maybe a few different adults may not think of, though, is the fact of like their renal state, right? The renal function is being affected. So, one thing to think about is you don't want to consume too much calcium because in older adults, this may lead to calcium stones or kidney stones because their kidneys are losing function. They're a lot more likely to end up with kidney stones, especially if they do too much calcium. So, too much of a good thing, right? Another thing to consider is kind of to make sure that older adults are getting plenty of all their nutrients right. We want to make sure that when we think of calcium, iron, zinc, these things don't really absorb very well together. They actually kind of compete for absorption. So, yes, I want to make sure they get plenty of calcium. However, I may want to make sure they do calcium rich foods outside of when they do iron or zinc or magnesium, because all those things are going to compete for the absorption of those. Last few nutrients to finish up is sodium and potassium. We know for older adults, they usually consume way too much sodium in their diet because of convenient snacking, not wanting to cook for themselves, or maybe not wanting to buy fresh foods and fresh meals all the time. So, as you get older, your needs for sodium decrease. 1,200 milligrams per day is what is recommended for the sodium for an older adult. Potassium does the opposite. Potassium has the ability to relax blood vessels and remove sodium. So, we want older adults to get plenty of potassium in their diet, especially through those fresh fruits, fresh vegetables. Both of these guidelines fit very well for the DASH diet. The DASH diet works pretty well for most healthy older adults, making sure that they get plenty of fresh fruits and vegetables, watching their sodium, and getting plenty of calcium rich foods. Now, part of the care of working with older adults is I want to remind you all that I have done an episode before on different nutrition programs or community nutrition programs that are used for older adults. So if you haven't listened to that, go to that episode, listen to where I go more in depth about different programs available for older adults. But just to give you a little brief of the different programs that are supported by the Older Americans Act, we have different programs like the congregate meal programs where older adults can apply and come get a free meal where they sit with other people. For those that can't leave the home, we have Meals on Wheels, which is going to bring a meal to them and drive it over to them if they're homebound. We have the Senior Farmers Market Nutrition Program, which is out there to give coupons to older adults to ensure they can get fresh foods at their farmers markets. If an older adult met the income eligibility, they may be able to get SNAP or Commodity Supplemental Food Program worked out. So we kind of know there's a few programs that do exist and why they exist. Make sure you go to that episode to listen back to them. Now, let's apply everything to 3 practice questions using the process of elimination. Number 1, as older adults age, the RDA for iron will blank and the RDA for calcium will blank. A, increase and increase. B, stay the same and increase. C, decrease, decrease. Or D, decrease, stay the same. As older adults age, the RDA for iron will blank and the RDA for calcium will blank. What's going to happen, folks? Well, starting with A, As older adults age, the RDA for iron will increase and the RDA for calcium will increase. Well, I remember the calcium increasing, especially due to the bone mineral density we talked about. However, iron, I don't think there's a specific requirement for them to increase it. I think it's going to be the same RDA as that of a normal, healthy, middle aged adult. So I might rule out A based on that. I could bring it back, but for now, I don't feel good with it and I would get rid of it. B, the stay the same and increase. As older adults age, the RDA will stay the same and the RDA for calcium will increase. I do like this as an answer. We know the RDA for iron is probably going to stay around 8 milligrams per day. The RDA for calcium is going to increase to 1200 for both genders there. I like that answer. I'm going to hold on to it. C. As older adults age, the RDA for iron will decrease and the RDA for calcium will decrease. We know this is not the case. The calcium is definitely going to increase, not going to decrease for us there. So I'm going to get rid of that one for answer C. D. As older adults age, the RDA for iron will decrease and the RDA for calcium will stay the same. Nope, neither of these are true. The RDA for iron is not going to decrease. If anything, it's going to stay the same, and calcium is going to increase. So I'd get rid of D. The best answer for number one, as older adults age, the RDA for iron is going to stay the same, while the RDA for calcium will increase there. Number two, older adults require a decreased amount of kilocalories in the diet due to A. Decreases in fat mass and increases in fat-free mass with aging. B. Increased need to maintain the adult's desired body composition. C. Increase in fat mass and decrease in fat-free mass with aging. Or D. Decrease in fat mass and decrease in fat-free mass with aging. Okay, so let's think about what happens to older adults. As we get older, they tend to retain more body fat and lose muscle mass. That's what we kind of imagine them doing classically. So let's read through each and see which fits with that and why it has to do with kilocalories. For A, a decrease in fat mass and an increase in fat-free mass with aging. No, we said the opposite, right? So decrease in fat mass, it's actually the opposite. They increase fat mass and a decrease in fat-free mass, so it's definitely not A there. B, increased need to maintain the adult's desired body composition. Maybe. Maybe I'll put a little question mark by that. What I'm a little weirded out by on this question is it says the adult's desired body composition. What does that mean? That means what they desire. So let's say they want to have a body composition of, a BMI of 40. Well, that's not where we want them, right? So I might rule out B because of the desired piece. I don't think that's a good fit. C, increase in fat mass and a decrease in fat-free mass with aging. This does seem correct to my answer of what normally happens in the physiological process for older adults. And D, decrease in fat mass and decrease in fat-free mass with aging. This is not going to be all completely true. We do see a decrease in fat-free mass with aging, but not a decrease in fat mass. Generally, it's going to go the opposite. So older adults require a decreased amount of kilocalories in the diet due to an increase in fat mass and a decrease in fat-free mass with aging. Number 3, a 61-year-old woman who is low income reports loneliness while eating at mealtimes since her husband has passed. The dietitian should help the patient apply for A. Home-delivered meal programs. B. SNAP. C. Emergency food assistance program. Or D. Congregate meal programs. 61-year-old who is low income reports loneliness while eating at mealtimes since her husband passed. The dietitian should help the patient apply for A, B, C, or D. A is home-delivered meal programs. This could work. It would give her some meal program use. However, it's home-delivered, and she's reporting loneliness. I feel like delivering the food to the home, although she'll get a little interaction with the person that delivers it, she's not really going to get to eat with anyone. I might rule out A because of that. Same with B. SNAP could help her out with her low income, but the only problem is here she's just going to be buying foods and cooking for herself. It's not going to help her mental state at all, so I would rule that out. C. Emergency food assistance program. Well, was this an emergency situation? It doesn't seem like it fit for that. Or D. Congregate meal program. What this would do is it would force her to go and have the meal with other people at a designated time and location. And the fact is she's feeling lonely at meal times. The best thing for her would be a congregate meal program, or answer D. That wraps up today's lesson, students. I hope you watched, listened, learned, and enjoyed today's show. Don't forget to join us for our upcoming live this Wednesday. Remember, passing this exam is a journey. We all need assistance along the way. Do me a favor, hit the subscribe button if you haven't, tell other studying students, rate, review, help spread the word, and remember, as always, happy studying to you, RD to be.